Okay, the moment everyone has been waiting for. And thank you everyone for enduring our AGM. Our first speaker is Dr. Kathleen Ross. She's a remarkable person. I don't know if remarkable is sufficient to describe her as a physician, a healthcare advocate. I mean, I've known Dr. Ross for over 30 years because we work in the same Fraser Northwest division. We were indeed founding members of that division of family practice and founding creators, co-creators, co-conspirators, maybe co-advisors of a little something called Pathways. But there's more. Dr. Ross is still a community physician. She serves her patients in the Tri-Cities area. I think she still does obstetrics. I think she had to get somebody to cover a call for this morning. I believe she still works out of the Royal Columbian Hospital as a surgical assistant in the cardiac room. She did take a little bit of time off. She had served a little stint as our president of the CMA in 2023 and 2024, and represented us with quite distinction at all levels of government. And somehow through all of this, she has found time to volunteer for the Rotary Club and sometimes to hula. She is truly remarkable, and I'm very proud to introduce my colleague and friend, Dr. Kathleen Ross. Take it away.
Thank you so much, John, for that kind introduction. And yeah, I think we do go back a long way, and obviously, for I go back a long way with Oscar because that's certainly been a driving force. But for today's talk, I'm hoping that we'll spend the next 20 minutes or so kind of exploring the emergence and the potential impact of Bill S-5 on Canada's digital health ecosystem, what that bill actually means, and why it should matter deeply to Oscar, BC. I'd always begin my talk with a land acknowledgement. I am joining you today from the traditional unceded territories of the Coquitlam Nation. But more importantly, I want to acknowledge that we make this land acknowledgement because it is a sign of the medical community's commitment to listening, learning, and walking the path towards reconciliation together. And it should carry deep impact and meaning for us all. But let's move from there onto what I've been calling a clear and present danger. And this is no longer theoretical. Governments have moved past encouraging vendors to data share to enforcement. And I'm going to talk a little bit about how that happened. But this legislation, while it's aiming to improve patient care by enabling that seamless data sharing and preventing data blocking, it creates several key paradoxes. Number one is that the policies designed to open access to medical data may instead favor larger vendors who can absorb the ongoing costs of compliance, and I will come back to that in a moment. But I do want to begin by saying a little bit how we got here, and that starts with what problem were we trying to solve in this work? And no surprise, I think many of us on the call live in this world where we work in multiple different places. I know that I do, as John outlined, and getting information from one site to another site can actually be limited, and it is, as my friend and colleague Ewan Affleck says, causing harm today. So we know that we want to actually address this and move forward. We are absolutely sure that we need to collectively modernize not just how we collect and store and share health data, if we're to shift our current workflow and lead that healthcare transformation. But we know that the lack of interoperability is an overarching challenge. So this slide I always start with because in the 2024 Commonwealth Fund, we saw that Canadian family physicians were well below other countries in their ability to exchange even patient summaries electronically with other providers, sitting only at 36%, with the Netherlands at 94%. And although those numbers are to be updated this year, they're pretty similar at first draft. And Ewan Affleck, as I mentioned, he's College of Physicians and Surgeons from Alberta, and his colleague Terry Price of Greg's Wings coined the phrase that interoperability saves lives. And I think this is a common experience and one that we as clinicians see firsthand. So, when I was president of the Canadian Medical Association, I asked my team to explore how Canadian physicians were using digital health tools, kind of get a sense of where we were starting. And this was part of a larger project on administration and administrative burden. But the end result was doing this survey with Canada Health Infoway, and I think any of you who actually participated in that. And what we saw was that we really have come a long way in a relative short period of time when we look at the adoption of electronic medical records. And we know that this is the foundation to health data interoperability. When I was president of the CMA, I had a long conversation with Manitoba Premier Wab Kinew about the need to look at interoperability, to look at collecting better information and moving forward, even on things like AI scribes. And I'll never forget because he had his assistant hand him his wallet, and from his wallet he pulled out a paper care card. This was just a year and a half ago. So we know that we have come a long way, but there's a lot more that we need to do, and we have to build some consistency across the nation. We're seeing progress for sure in the adoption of other electronic tools and functionality, and we'll hear a little bit more about the e-referrals when Dr. Gershman talks later. But some of these are still pretty low in their uptake, so we know there's lots of room for improvement. These results also provided another look at the communication channels that physicians use, and again, progress from previous to now, but still a long ways to go. And while we know that most physicians in Canada are now collecting clinical information electronically, sharing across systems still sits well below 50%. The other component of that is that we know that it is overburdening our providers at a time when we face unprecedented challenges related to an insufficient health workforce. And I hear my colleagues all the time complaining about excessive administrative burden that's taking time away from time with their patients. But keep in mind, this is actually also time with our families and time for self-care. But this particular slide really helped cement in the minds of decision makers that administrative burden was a significant challenge, and that one of those challenges we needed to look at was acceleration of interoperability. And to that end, we formed a digital health interoperability task force, which I'll speak about in a moment again. These results were of particular interest to me, but maybe not a surprise to those of us here. Digital health systems are highly fragmented across every organization providing care. And some provinces and territories have done a little bit better, but most physicians just don't experience that seamless sharing of information. And unfortunately, this is causing a great deal of excessive burden, as we saw on the previous slide. And finally, and this was another reason that accelerated the work towards this legislation, is that respondents to this survey stated that they needed to access data from outside of their primary practice setting for 50% or plus of their patients. And as I mentioned, this is taking time away from clinician days, time with family, and time for self-care. So it really is no wonder that most of us feel like this every day. And when we started the CMA at the CMA to advocate for interoperability legislation, I kept bringing this image forward because really no one's hair should be on fire. So as I mentioned, we did start the Digital Health Interoperability Task Force. We actually started this in 2003, and that was bringing together the leading national physician organizations, including the CMA, the College of Family Physicians of Canada, and the Royal College of Physicians and Surgeons, alongside Health Infoway and other leaders. And there was a total of 17 senior leaders from across the country, many with experience and understanding of that digital health landscape. We had patient and nursing representation, but we were really able to provide that physician perspective on the current state of interoperability in Canada and the lack of interoperability. And the government, when we were meeting with them and chatting with them, were really surprised that we had not to date incorporated that frontline physician voice at a national level on this subject. So for that work, we came together over 8 months. We identified the challenges faced by providers, by patients, of that inadequate interoperability. And we worked together to kind of define what a truly connected digital health environment should look like from a physician perspective, and identified barriers and opportunities. And we certainly recommended actions, but our overarching goal was to ensure that implementation was realistic and practical at the front lines. And we did release a white paper in 2025 that was widely disseminated, and then just recently a second white paper was updated and released. But I think it's important to note that the physician voices on the task force were not voices crying from the dark. Like they really did support a number of national initiatives, including the introduction of Bill C-72, now Bill S-5, to prohibit that data blocking and establishing requirements for interoperability and health data standards that health information vendors would have to follow. Again, health data standards with Infoway and CIHI. You've probably all seen the shared pan-Canadian interoperability roadmap that was led by Infoway, and really having a modern framework for health data stewardship that's being led by CIHI. But challenges remain. And current progress on these national initiatives remains slow, and I would include the legislation before us in that slow pace. There's a lack of collaborative national governance. We don't have an overarching plan with proposed deliverables and milestones ahead just now. But we do recognize that that's going to have to be supported by explicit provincial and territorial agreements and commitments that the federal government will not be able to mandate. Current privacy legislation, not news to anyone in this community. It's really not fit for the digital age and impedes data sharing and the appropriate use of data. And I always say it's much more easy for me to find out information about my banking and even my Uber Eats orders than it is for me to find my own health data as a patient. So we have a clear gap. We also need best practice guidelines, and I think that's where Oscar BC excels. That's for clinicians and organizations, which can result in risk-averse behaviors where we feel like we're out on our own. And most importantly, and in our first paradox, despite the overall support for current initiatives, there's a fundamental disconnect between the approach taken by organizations and governments to address the interoperability of health data and the perspective of Canadian clinicians. And unless we address that, interoperability initiatives will add to our burden and could very well lead to failure of well-intentioned efforts to stay connected. And I would argue that no one has really thought this through carefully. We know that there are challenges that we all face, and we just don't have plans developed at any level of the provinces or territories for that last mile initiative. How do we prevent burden? How do we actually get providers to collect, standardize, and curate their data without taking more hours away from our patients and certainly without destroying our souls? And we do need to look at current provider workflows and make it seamless. Looking at the tsunami of data that comes into my inbox every day and trying to deal with that in an organized fashion is got to be on the list. So the task force did communicate that we felt there was an urgent need. And that's part of the pressure that you see with acceleration of this work through the government, is that we have consistently said that we do need to fast track tangible improvements in interoperability, and accelerating that through existing policies and legislations is critically necessary. We also recommended, in addition to a few other key components, that Canada commit to research and development funding for organizations to allow us to invest in continuous innovation in digital health. And we didn't see that in the bill. So if our goals are to, have access to timely information to inform care, to have those critical transitions in care and collaboration, provide patients access to their data, which many across Canada still do not, to be able to garner some data from our EMRs so that we can better inform health system planning, and of course, reducing barriers for entry for vendors and initiatives, because 100% we know that innovation happens on the fringes. And any move to consolidate data in a few large buckets is going to reduce or possibly even eliminate innovation. So for Oscar and other community-based and community-led EMRs, this should raise questions and concerns about sustainability, about innovation, and market consolidation. And yet, to move forward, it's pretty clear that no one entity can do this alone. We're talking about EMRs to applications to provincial and territorial programs and infrastructure. There are multiple layers to consider, but foundational to all of these is government policy. And government policy in Canada is really, it is led by legislation. So if we have a look across this comparator slide, these are countries that we actually looked at that employed similar standards and legislation. And all indicators are that these principles resulted in successful digital patient access platforms, something that Canada probably wants to emulate. Underneath all of this legislation was interoperable data standards, strong government legislation, and conformance programs that provided a good framework to move forward. And I'm really certain that folks will have heard of this before, but as we're having these discussions on interoperability, we actually have to consider that there are probably three and maybe more definitions of interoperability. So we talk frequently about health data interoperability, the ability to access, exchange, integrate, collectively use data. That's one. The technical factor interoperability is that data content standards and technical considerations that are required to enable that secure access and integration of EHR data. And then finally, and I would argue most importantly, is the human factor interoperability. Those system level relationships, those communities that impact our capacity for health sector stakeholders to really adopt a harmonized data standard and technology. And we're not there yet. So, Bill S-5. On February 4th of this year, the Government of Canada introduced Bill S-5 that connected care for Canadians that will fundamentally reshape how EMRs operate in this country. And this was the second time such a legislation was introduced. And you could probably tell from my grin here, this was on June 6, 2024. And I was pretty pleased and pumped that then Minister of Health, Mark Holland, that we had been working with on this bill, had agreed to introduce this work into the House of Commons. Now, unfortunately, that bill did die on the floor when the government election was called. And as such, Bill S-5 was introduced in the Senate. And really, it was designed to improve patient care by mandating interoperability and preventing and prohibiting data blocking so that we could ensure that patients' personal health information could move seamlessly across the systems. Those shared goals were reduce fragmentation, enhance safety, and modernize access to data. But again, this legislation prevents or presents many critical paradoxes. While the legislation is aiming to open access and democratize data, it's unintentionally or could unintentionally concentrate power among large vendors who are better able to absorb the significant and likely ongoing costs of compliance. And I'll speak about that in a moment as well. Requirements for continuous API development, security standards, regulatory oversight, all of that creates a disadvantage for smaller and open source EMR platforms. For the BC context, and where I think OSCAR BC plays a vital role, is in supporting that community-based care and clinician-driven innovation. So this raises important concerns because without that thoughtful implementation and regulation, Bill S-5 risks accelerating vendor consolidation, reducing diversity, and undermining the very flexibility and responsiveness that we as frontline patient care providers really depend on. So success isn't going to just be based on the content of the legislation or of policy. It's really going to be on how it's implemented. And I would argue that we do need a more balanced approach that treats interoperability as shared public infrastructure that supports smaller vendors and preserves that diverse and innovative EMR ecosystem. So where are we at in this bill? And I think this is really important. It's important for people on this call. It's important for all of us that are providing care. This bill was introduced February 4th, 2026. And in a very short period of time, it progressed through all three readings at the Senate, with the final one being on May 26th, passed through Senate committee. There was a lot of testimony from users, from Infoway, from EMR providers. This was a very well engaged committee meeting, but it happened with speed and at pace. The first reading was introduced in the House of Commons on May 28th and passed, and I am anticipating that that legislation is going to go very quickly through the next several stages, possibly even being passed in the next few weeks. But what this means to us and why it's important is that it's not yet law. It's got government backing and it's clearly got momentum. We're moving quickly through this. But before we get that House of Commons approval, before we move through to royal assent, this is the window to influence implementation. Now, I want to just try and go through some of the core requirements in the bill. And the first of those, it's obviously it's focused on health data interoperability, but it's designed to ensure that systems can exchange data and that vendors cannot block access to data. And this applies to all IT vendors, including small and open source EMRs. Mandating interoperability means that vendors must ensure that their systems are interoperable. This is not optional. This is not driven in any way by a market change or anything else along those lines. And these are ongoing obligations, not a one-time build. They define that as systems that can access, use, and exchange health data completely and securely. It captures everyone. Talks about prohibiting data blocking. And data blocking includes anything that prevents access, discourages sharing, or interferes with data exchange, but it's not well defined. And that means even indirect barriers like user fees, like APIs, other possibilities, they could all be regulated, each of them bearing a cost. And as I said, there's a pretty broad scope that's captured in this. It applies to the EMR vendors, the software developers, platform providers, service providers. The definition of health information technology is super broad and not well defined. And that means that even smaller or niche developers are going to be captured by default. But let's not forget that we don't have one national system of healthcare, that we have 13, 14, if you count the military, of federal and provincial areas of jurisdiction. And this legislation has stated that this new jurisdictional reality will only apply to those provinces that opt in or lack equivalent laws. But the catch is that there's really no definition in the bill of what's close enough, like what is an equivalent law. And that means that provinces can add requirements, they could enforce their own compliance rules, and Oscar may well face both federal and provincial compliance layers to meet this need. But Oscar's BC, oh, I left the BC out there. Context, we really know this is a widely used open source. It thrives on flexibility and clinician-led information, but it's a small, although engaged, community of users. It is still small. And the hidden reality for small vendors, we're not really sure yet. And I think you might well ask, what does this mean for us? Well, the truth is, nobody knows yet. And that's one of the largest risks of implementation facing this bill. It doesn't just say that you will be interoperable. It implies that there'll be continuous API maintenance, that there'll be security compliance, that there'll be certification readiness. Ongoing upgrades are built in, and that means that there's a permanent cost structure that needs to get built in and funded. And there is a structural imbalance. I've started calling this the compliance tax because we have large vendors who can scale compliance costs. They can monetize integrations, and they already often have that developmental infrastructure. And smaller open source vendors got limited capital. They're volunteer or community driven, as you know, with Oscar BC. And then there's really less bandwidth in the organization to report on regulatory compliance. So this does become a compliance tax because interoperability is not going to be a feature anymore. It's going to be a requirement that's ongoing and ongoing costs. And that, if you look at how we compare smaller vendors and larger vendors, there's a disproportionate burden per user on the smaller vendors. And that puts us at risk for market consolidation. because we could very well see that smaller vendors will exit, larger vendors are going to dominate, and innovation will narrow. And I think it's really important to understand that this isn't theoretical. This is how other jurisdictions have evolved in response to this legislation. The other point to consider is that Bill S-5 creates a legal obligation for health IT vendors to meet those interoperability standards and the data blocking, but it doesn't currently contain a dedicated funding mechanism for small EMR vendors to achieve that compliance. And details are expected to come later through regulation. And I had a number of discussions with Infoway leading up to this, but of course that's changed. Now, historically, Canada Health Infoway has been our national organization to provide much of that interoperability infrastructure, standards work testing environment, conformance programs, vendor support programs, and innovation funding that has helped small vendors move forward. Mackay has had a lesser role in these processes to date, but if, as we heard and learned this week, federal funding to Infoway will be significantly reduced or canceled outright, there are a couple of new and emerging risks that we should consider. Large vendors, as I mentioned, can absorb the cost of IT and conformance testing, certification, etc. Smaller Canadian ENR vendors can't spread those costs out across a large consumer base, and that could be higher costs for clinicians and physicians that may force us to change. Vendors consolidating, I've said a couple of times, and we may well see small vendors exit the market. But I am concerned about the reduced competition and innovation. And this is precisely the concern that many physician groups and smaller EMR companies raised, both formally and informally, during these interoperability discussions. And the testimony inside of the Senate committee was very informative. But we also see that Bill S-5 could unintentionally favor those large incumbents. And if I harken back to my slide at the Digital Health Interoperability Task Force, our advice in that white paper, and again in the updated white paper, was to reduce barriers for entry for vendors and innovators. And without that transitional funding, quite the opposite can occur. And it's going to be much easier for a large multinational vendor to absorb costs than for smaller Canadian firms. Provinces may be able to step in. In many ways, they could be forced to step in to preserve that diversity. But this is at a time when budgets are tight and every province is facing budget shortfalls. But we will need to look at how the government can support funding conformance testing programs, developing those interoperable gateways. And perhaps that's going to be grants or subsidies to smaller vendors. But all of that increases the risk of fragmentation. And that was one of the challenges that Bill S-5 was intended to solve. So I promised pitfalls and paradoxes. So I think that we need to have a look at this slide. If interoperability becomes an unfunded mandate, Canada may achieve interoperability standards while simultaneously reducing the diversity in our vendors, increasing costs, and concentrating market power, market share around a few large technology suppliers. So the greatest implementation risk for Bill 5 isn't the legislation itself, which in many areas is vague and unhelpful, but it is the loss of the enabling infrastructure required to help small vendors comply. And I'm happy to share this slide deck later, but one of the strongest arguments that we need to make for Parliament and certainly the Senate committee heard that was who pays for interoperability compliance. Is this meant to be the federal government, the provinces, the vendors, the frontline clinicians? The bill establishes the obligation, but the long-term funding model remains really, really unclear. And although the intent might be national standards and reducing data blocking and certainly better competition, I suspect that we're actually going to see increased dependence on dominant platforms, higher costs for community practices, and certainly reduced competition among EMR vendors. And as I mentioned earlier, and please don't forget that part, there is legal ambiguity, and that presents a risk for smaller vendors when you have to start layering in legal costs on top of compliance costs. So In my concerted opinion, what I think good implementation would look like would be to develop that shared infrastructure, whether that's a national or or provincial level API layers, but we want to support this as part of critical healthcare infrastructure like hospitals. I think this could be a program to develop. We need that middleware support, even extending AI programming or IT development support programs to innovators would help to address that. There's no question that smaller vendors are going to need grants for compliance, and if we want to maintain open source, we're going to need support for that. The other potential future is, is tiered requirements. Like, could it be that we have compliance that's based on the size of a particular platform? That's possible. But without that, really, legislation risks harming the whole ecosystem. And I appreciate your patience. I do have just a few more slides. So, what is the opportunity for Oscar BC? I think that Oscar BC could become a model for community-driven interoperability. This is critically important. Oscar BC could be a lead in the open source interoperability modules and advocating for that shared standards implementation alongside ensuring that this is part of public infrastructure. Oscar has already demonstrated the power of community-led data stewardship, shifting away from individual data ownership in our practices, but to that community level. And I think there's more that can be done. So I do see three futures, and I think as the next year unfolds, I hope that your board will consider some of these and decide which one as a community we want to see and work towards. We certainly could go down the compliance strain and meeting the needs, but I fear that might lead to exiting of smaller EMRs and open source and consolidation. We could look at collective adaptation. Oscar's very strong in their YouTube videos that they post, but this is some way that we could build further on the community and to build more of those shared tools. And then the third, of course, is about leadership, and I was pleased to see that in the AGM presentation just now that Oscar BC could well define how open interoperability works in Canada, in line with the goals to actively support members in adopting and implementing EMR innovations, including AI. So in my brain, adapting in this age of interoperability will continue to require the deep understanding of technology that Oscar BC is well known for, alongside the regulations, communicating and having that clear vision, modeling that culture of innovation and why it matters, and finally, leadership and political advocacy because it's pretty clear that Bill S-5 is not just about interoperability. I hope that I've been able to demonstrate that this really is about who will shape the digital health ecosystem in Canada. And if we do nothing, interoperability will be defined by scale. If we act, it can be defined by community, openness, and patient-centered care because interoperability should not become a barrier to entry for innovators in our health data ecosystem. It really should be a bridge to innovation. I mentioned a bit earlier the timeline for this bill, and I think it's critical that folks on the call here know and understand and share this opportunity because we do have active feedback going on right now. The CMA started a letter writing campaign this week. Uh, yes, to support the bill, but I'm going to argue that it's also the time that we should be asking for policy for fair interoperability. Because if interoperability is going to be legislated in Canada through Bill S-5, then we have a responsibility to try and get that implementation right. Because right now, there's a real risk that we unintentionally create a system where only large vendors can comply. And in doing so, we lose the very innovation and flexibility that community-based EMRs like Oscar and Oscar BC's work to bring patient care to the next level. So asking our government, I don't want to ask them to slow down. I think that's the wrong ask. Supporting the bill, moving forward, but ensuring that we have the capability to do it differently. And finally, I know that the road ahead is winding, and I know that there's going to be many curves and switchbacks ahead. But what I've witnessed today with Oscars BC's committed community, I'm really confident that some of the challenges that I've described are going to be met. And I think with that, John, I'll hand it back to you and end my presentation.
Thank you, Kathleen. Much more than I expected. And apologies if my video appeared in her slide. I don't know how to turn that off. I logged out and logged back in the hopes that it wasn't a distraction. Um, OMG. Um, you know, 20 years ago, interoperability was one of the key buzzwords for adopting an EMR. We all remember, if you're in BC, the PETO days, where that was one of the entrance requirements, if you will, for an EMR. Oscar was a little fractured at that time. We were not one of the chosen ones, and were roundly written off. We were just not given, due consideration. But of course, 20 years later, we're still around in quite force. I mentioned that change was forthcoming. I only scratched the surface there. We can see there are serious concerns, despite what needs to happen. And we did not know the contents of Dr. Ross's slides. We did not ask her to endorse Oscar BC in any way. We gave her free reign. I do thank you for supporting us and indicating how important it is for the grassroots to have their say. Both Dr. Ross and I were involved with a similar situation some 10 years ago, where a small vendor, if you will, had to go head to head with a large vendor. And that's why I made the reference to not leaving the landscape irreversibly charred. Bit of an inside joke, but quite important. Interoperability means something very different today. It is not what I expected, but we need to speak up and act accordingly. Otherwise, the technology will control us rather than the other way around. I'll stop there.
Excellent. Thank you, Dr. Ross, for a very informative presentation. Lots to think about, lots for Oscar BC and its board to form its just forthcoming discussions, and how that feeds into our strategic priorities moving forward. Is there any other comments, anybody, or questions anybody would like to ask of Dr. Ross while she's with us regarding her presentation?
Oh, I just wanted to add, sorry. We tried to get Dr. Ross to speak at Oscar Cons for the last 2 or 3 years. Third time was the charm, and well worth the wait. Thank you. I can't thank you enough.
Yes.
It was a
Yeah.
pleasure to be here, and I'm happy to answer questions. People can reach out to me either on LinkedIn or I suspect many on this call actually already have my email address, but always happy to be there. And I'm looking forward to your next speaker. So I'll turn off and fade into the background.